and then it's performed, and then either there's a complication or a failure, and that reinforces why it should not be used. So what Dr. Baumgartner said is absolutely key. Get the experience, get the technique. It's not particularly difficult if we take it step by step, think it through, and achieve each step before going on to the next one. And once you do that, I think you're going to enjoy success. Your patients will enjoy success.
Okay, if those people who are standing at the back would like to come and sit down at the front, do feel free. Lowell, you just commented to me you'd like to make a comment.
Yes, I would like to comment on ascending superficial phlebitis, and I think we need to differentiate between varicophlebitis and spontaneous phlebitis. I think Tony's comments this afternoon were right on target with spontaneous phlebitis and the incidence of hypercoagulable or thrombophilic states. It's not so much that in our varicophlebitis. So I think we need to differentiate between the two of them rather than lump sum them. And I would be more aggressive with a spontaneous ascending phlebitis because I think that they don't have as much inflammatory component, and I would think that they would be more likely to embolize.
I think Dr. Kabnick is apologizing for opposing my opinion.
Andrew McKervin.
I was a bit surprised by the aggressive treatment for varicophlebitis, because I usually tell patients that, well, what's happened naturally, and it'll end up much the same as Jonathan's foam, but without the foam. And it's actually quite a lot of those patients will then treat themselves and cure themselves spontaneously.
Well, I agree with you that it is quite aggressive, but in the acute setting, I don't think at this point there's no literature to tell us that we need to intervene. And in my short tenure of practice, I haven't intervened, and fortunately.
Well, if the great saphenous vein is involved with thrombus, recurrence rates are going to be high, and then with recurrence, you run the risk of extension into the deep system, and the associated costs. So if you have an opportunity to get rid of it with a little linguinal cut down, why not do it? I mean, you're talking about. Well, not really, not really, because you're not going to be able to get that catheter up a recanalized vein. An acutely thrombosed vein that you take the clot out of is very easy.
Most of the time you can snake a wire up, Tony, through it if you give it time to resolve. And I certainly agree with you. The question is the timing, when to do this. And the literature says if we should do it, but I kind of agree that there is a time that we really need to do this because recurrence rates are high.
I agree with you, Andrew. Because I end up seeing mine at 3 to 4 weeks, it's always too late for any of this sort of stuff, and I send them away for 6 months. And then I bring them back, and about half of them recanalize, and about half of them stay thrombosed. And I congratulate the ones that are thrombosed, and then I treat the ones that are recanalized.
Okay.
I just want to mention that, yeah, you said...
Give the microphone on, please.
You said varicophlebitis, but varicophlebitis, of course, the discussion was around great saphenous vein phlebitis, so that's a completely different thing, I think. And then we have to separate varicophlebitis or a superficial phlebitis of a side branch and great saphenous vein phlebitis. And those three issues are very different. And that brings me to a question, if I'm allowed to, is that if it's also known that superficial phlebitis is also goes together with an incidence of carcinomas, oncology. And what's your opinion exactly about that? Because you talked about deep venous thrombosis.
Exactly, but don't forget I tend to be talking about people who are over the acute event, when I think that the rate of DVT in these patients is low. But I agree with you about the business about hunting for a carcinoma, and in the appropriate age group I would do the routine tests. I wouldn't normally do a CT scan, but I'd certainly do a chest x-ray and the bloods and a physical.
And do you then also separate between a varicophlebitis and a side branch phlebitis in a healthy vein? Because that was a debate a few months ago on another meeting, and that the incidence of a carcinoma is much higher